this sort of radical idea. I think the U.S. Preventive Task Force should take on screening semen analyses.
Great.
This is what we're talking about.
That's a great idea.
Yeah.
Right? And it's the male pap smear, essentially, is what you guys are saying. I mean, I know it's not the same science, but to somebody like me, I understand that.
I had somebody tell me that a semen analysis is cheap, easy, and pleasurable to collect.
Easier than a blood draw.
Easier than a pap smear.
Yeah, true.
Or a mammogram.
Don't require a doctor to be there.
Don't require a doctor. So I'm pretty bullish on the possibility of, when done thoughtfully. Paul, I know that you also taught me a lot about the complexity of QAing a semen analysis. They're not perfect. None of these tests are. But if you do them serially and thoughtfully and with context, I think there's a lot of potential there.
Hello, everybody, and welcome to episode 2 of Talk with Turek. It is a podcast about men's fertility and sexual health. My name is Rob Clyde. I am a filmmaker and former patient of this guy,
And I'm Paul Turek of the Turek Clinic.
Dr. Paul Turek, who is a reproductive urologist. That's
what we are.
Your official title as
Pretty
a doctor?
much, yeah.
Okay, and classic car enthusiast?
Yeah, that came to light this morning on my way in.
So, Paul, you're into classic cars.
I drivers, not restoration stuff.
And so
this is
when you come in here to the podcast, is your chance to drive one of your cars in, enjoy the drive, and
the car thing. My dad's a welder and from Czechoslovakia, was a blacksmith, and when I grew up as a kid in Connecticut, I wasn't able to play basketball on Saturdays with my buddies. He made me work on cars, and, hold the brakes and hold the bolts. But when I got older, maybe a surgeon, because I work with my hands, and I can hear things happening to cars before it happens. So I do the same thing with men. Men are like old cars that you got to pay attention to them and look for little things before they get big.
Yes.
And so it served me well as a surgeon and a men's health specialist.
It's a great analogy.
No check lights, etc. Right?
That's right.
But today I was driving in, and I have an old car, and I had to get some old tires, so I had them sent on eBay. And I get these old tires to the car shop early in the morning before this. And I used Waze, but my daughter, last week we were together, and she said, I don't like to take the highway. She was driving and she put no highways. So I went through 400 stop signs, 300 lights, and 1,200 streets. And then I tried to change it and couldn't.
Most frustrating. Well, you learned a little bit about
At the last minute, I learned what happened.
So that was your crazy morning trying to get here, because we have a guest on this episode, Dr. Neel Shah.
I love Neel Shah.
Of Maven Clinic, which is the largest telehealth clinic for women and families. He wrote an article about you, and I read it. It's very flattering. It talks about...
That's a preprint Substack article.
Correct. So we're excited to bring Neel on today and talk about some of the inequities in between men and women's health.
Yeah,
that'll be really great.
Yeah, I'm excited.
Speaking of this being episode 2 of our podcast, I watched the first one and immediately went on a diet. I mean, I have been starving myself. It was shocking to me.
What led to that, dearest Rob?
I mean, I'm vain, I think. I think I have vanity. I got my hair cut last night for this, but I'm like, what am I going to wear? So, because podcasts are supposed to be audio only, we decided to do video.
Yeah.
So now we have to kind of look good too. And men have vanity, don't they?
Yes, they do.
I just started working out at a place in Pasadena. It's for people that are over 40. It's like a boot campy kind of semi-private thing. And I didn't want the hoorah. I really said to them, I don't want people around me going, you can do another one, Rob. You can do it. I really don't want that. But I have started going. I've been doing it for about 7 weeks. And I like the people. They don't give me too much hoorah, probably because I look at them. But it has been great to have those group of people to see every Monday, Wednesday, Friday.
My favorite patients are men who come in and say, I've got this under control. My career's going well. Maybe I have a family, maybe I don't, and I just want to know what's next. And those men are the ones you can empower and say, okay, here's where we are. You got a little this, a little that, it's preventative maintenance.
Totally. All right, we could talk about me and my weight forever, but we have a great guest to get to. So our first guest on Talk with Turek is Dr. Neel Shah. Let me also preface that this is quite a bio. that I'm getting ready to read. And any man with a bio like this deserves to sit and listen to it be read. So enjoy it, Neel. Enjoy it. So Dr. Neel Shah is Chief Medical Officer of Maven Clinic, the largest virtual clinic for women's and family health, and a visiting scientist at Harvard Medical School. He is a globally recognized expert in designing solutions that improve healthcare and is listed among the 40th smartest people in healthcare by the Becker's Hospital Review. His work to build equitable, trustworthy systems of care has been profiled by the New York Times, Good Morning America, and other outlets, and is featured in the documentaries Color of Care that was produced by Oprah Winfrey, and Aftershock, which is currently streaming on Hulu. Dr. Shah has written more than 50 peer-reviewed academic papers and contributed to 4 books, including as senior author of Understanding Value-Based Healthcare, which Don Berwick has called an instant classic, and Atul Gawande called a masterful primer for all clinicians. And by the way, Atul Gawande is his mentor that I heard in another podcast that Neel did earlier. I'm really excited to talk to you about that. Prior to joining the Harvard faculty, Dr. Shah founded Costs of Care, an NGO that curates insights from clinicians and patients to help delivery systems provide better care. And in 2017, he co-founded the March for Moms Association, a coalition of more than 20 leading organizations to increase public and private investment in the well-being of mothers. Dr. Shah serves on the advisory board of the National Institutes of Health, very important, Office of Women's Health and Research. Ladies and gentlemen, Dr. Neel Shah is our guest today.
Dr. Neel Shah, so glad to have you on.
Thank you, guys. I appreciate it. We should immediately lower expectations. So we gotta figure out that better.
Neel, I have a question about this bio because it's pretty spectacular. The question is, what's your proudest accomplishment?
Well, it's hard to characterize this as an accomplishment per se, but I definitely married up. So I met my wife when we were 14. I wasn't dateable then. Mm-hmm. As she will tell it. There's different versions of the story. I had to very slowly wear her down. But now we're married, and we've got 2 great kids. So I'd probably have to go with that.
You married up. Okay, good.
That's a great answer, right? I also married up pretty well. You know, I'm the everyman on this podcast, and I'm expecting a couple of intellects here to be discussing some pretty highbrow stuff, but I'm excited to deduce it down so that every guy that's listening today can really understand. I read your blog, preprint, and I first read the one that you did about Paul.
Yeah.
And in that blog, you kind of termed or coined him as a fertility futurist.
Yeah.
And I think I would love to know what you meant by that and use that to kick off our conversation.
I meant it like literally, like a person who has a point of view and thinks about the future of both the fertility industry, but all the implications of the industry for like humanity. But I think, you know, the fertility futurist is a version of my favorite kind of person, which could be applied to a lot of different things. It's a high compliment, Paul. But
sweet.
There's I feel like in 2024, the word design or designer in the technology industry gets overused a little bit. It's a little bit of a term of art. There's a Princeton professor who's now deceased, one of these like polymath people. I think he was technically a political scientist, but ended up making contributions to everything from economics to like computer science. And his name's Herbert Simon. And he says the definition of a designer is anyone who changes existing situations into preferred ones, which I just love. It's so simple.
Same.
But like my favorite kind of people are people who are always sort of thinking from that mind frame.
I would agree with him that you're a fertility futurist.
Well, I do like to think about the future, and I'm not happy with the present. I'm not certainly with men's health, and yeah. So I think about things like how do we shorten the difference in lifespan between men and women of 5 years, right? The richest man lives 5 to 6 years less long than the poorest woman in America. I think about that, and I think about the fact that our Western system is a little bit too reactive and not as proactive and preventative as it could be. And you've stated that a little bit. It's not really built that way. It needs an overhaul. Yeah, those are a couple of examples.
Absolutely. I actually want to jump in really quick and for our audience, give a little context of what Neel does at Maven, and what Maven is, because clearly we want to do what you're doing for men.
Yeah,
we see the disparaging difference between men and women's health. And so if we can hear a little bit more about what you're doing
Neel
with
Shah,
Maven,
the blueprint.
yeah, what you're doing and how you're designing.
Let me back up a little bit and like give you a little bit of a sense of who I am, because I think that informs like my point of view. But and I promise I'm going to like zip to the present in Maven pretty quickly. But I grew up in an immigrant household. My parents came over on H-1B visa as Indian immigrants. And as immigrants are, they're pretty straight-laced people. So like predictably, I'm an Indian person from New Jersey who went to medical school. Like, not shocking, right? My grandparents, though, were like revolutionaries. They were part of the movement to decolonize India. And I think that activism is probably Mendelian or something. Like, it skips a generation genetically. Like my parents were like the more pragmatic ones, but because I grew up with both my parents and my grandparents, I think I developed a healthy respect for radical thought. And at a few key moments in my career, I kind of blew it all up. So I went to medical school. It's an aside, and I can tell you about it if you're interested. I took a break from medical school for a while and did something like totally apart, almost didn't come back. When I was finishing up my training, I had planned to go back to New Jersey and hang a shingle, but Atul Gawande, who you mentioned, kind of convinced me to stick around and become a professor. And then after about a decade of academic medicine, I kind of blew it all up again. And through a combination of, I think, probably midlife crisis and pandemic ennui, I gave all my grants away, gave up my really cushy academic appointment at Harvard, and decided to join a startup. And that startup was Maven Clinic, which at the time had a little bit under 200 people, but now has nearly quadrupled that, covers 17 million lives, and is the world's largest clinic for women's and family health. So that's my quick story.
Bravo, Neel.
What are you doing for women and families?
So the business is we design and administer reproductive health benefits, and we work with anyone who purchases healthcare in bulk, so primarily employers across almost every industry, from tech to finance to retail. But we also work with Medicaid plans, we work with unions, and so we have this really diverse cross-section of people that we serve in the US and abroad. And basically the model is, if you think about it, the brick and mortar healthcare system, Paul, you highlighted some of the ways that it doesn't work, like from a really macro perspective, the life expectancy gap for men, for instance. I think the thing that system will always be bad at in perpetuity is reliably showing up for people when they need and expect it to. And I think what digital health can do, like, you can't deliver a baby through a screen, I'm an obstetrician, so like that sticks out.
Yeah.
But like what you can do is show up for people when they need you to, like between shifts or at 2 a.m. or while they're traveling. And I thought that capability was really cool. It was really compelling to me. So I wanted to be able to deploy that to make people healthy and prove that it could work. Again, if you think about it, I had, when I turned 40, that was my time to go replug in to the healthcare system. And, during my 40s, I developed an autoimmune chronic condition, which is rare for an Indian man. But I think maybe it was COVID induced. I'm not really sure, but I ended up replugging into the healthcare system. And my doctor was like, there's medicine you can take, but fundamentally you need to eat better, sleep better, and be less stressed out. Exercise more, the things that but are really, really hard to do without help. And it was really clear to me that my doctor had fulfilled his obligations by telling me that, but then I walked away thinking who's there to help you with that? And I think what digital can do is actually provide with that missing piece, which is the coaching, the accountability. The thing about digital is you don't have a captive audience. There's no waiting room. So you're always competing for people's attention and have to actually produce good experiences for people, which is something the brick and mortar system doesn't even attend to. So I think there's a lot of potential there.
So just your opinion, your work with the NIH, what can we do in this country to get these numbers more equal, that men are dying sooner, that are less healthy, and that it costs more for us to fix our reproduction?
That's a big question.
Well, I'm sure Paul has a point of view I'm very interested in. It's probably going to be the evergreen conversation that we have for the duration of our careers, but because it is a big question. But I think, Paul, it was, the conversations I started to have with you that helped me start to form a point of view on this. I had read a couple of years back, it's not just that there's this disparity in life expectancy, is that the male life expectancy is actually declining, right? Like after centuries of gains, all of a sudden we are living in a moment where men year over year are living less long. And that's like really hard to understand, especially as an OBGYN who made my whole career pointing out gender disparities the other way. And like, I don't have a great explanation except that at the point of service, I think women get the raw deal, right? Like women are less likely to be diagnosed with a heart attack. Women are less likely to be attended to when they express concerns about pain. But I think in healthcare, as it pertains to men, we have what a marketer would call a top of funnel problem. Like men are also much less likely to engage in the healthcare system in the first place. We're half as likely to seek out mental health care. We're much less likely to adhere to treatment plans. So there's something going on with men, I think, before we even encounter the healthcare system.
Yeah, let's review some facts. I remember looking these up. So men lead in 9 out of 10 causes of death in America. 80% of suicides are men. So it's 4 times higher rate in men. And that's a classic issue of care, And of course, we talked about the 5-year difference in life expectancy between men and women. The average black male lives barely long enough to collect Social Security in America. 40% higher cancer death rates in men than women. And the cost to the system of neglect of men's care, men's health, is about average, estimated around a loss of productivity, et cetera, families, is around $300 billion a year in America. So that's little groundwork on what we're talking about.
One of the things that I love about, Paul, your approach is, it starts with this premise that men deserve empathy, which, ironically, is not really a popular point of view at this moment in some ways. I think that, not to make this political, but there's no question in my mind that, the zeitgeist right now in this political moment is driven by, the fact that men are suffering, I think. And doing less well. And I think the only pathway through it is to have empathy for men.
That's certainly the start, empathy, right? To acknowledge it, awareness. Yeah.
I feel like there is also a trend for men to take their health more seriously. At least that's what we're trying to do. So there are the Lululemon men, the ones that are doing yoga, that are watching podcasts like this, that their wives are telling them, hey, you need to be taking prenatal steps just like I am. I wanted to tell you both, I was getting my hair cut yesterday because I'm vain and I want to look good. Thank you. And the girl that was cutting my hair, her name was Alex, and she said, oh, you're getting a haircut? And I was like, yeah, I'm going to be hosting a podcast tomorrow. Oh, what's that about? Men's fertility and sexual health. Oh, well then maybe that's great. You can let them all know that it's their fault that I had a miscarriage. Right? And that was right on. The first thing was, I want my husband or my boyfriend or my partner to take responsibility for his half of the miscarriages that I've had. And I said, well, I have actually heard that the quality of the sperm can also affect the quality of the pregnancy or the, outcomes. And the outcomes. And so I am doing this podcast so that men will take responsibility for their part of fertility, and get on board with the trend that we can be healthy. That's the simple thing that I am getting from Paul every day, and I am getting from you as well. Is your fertility comes when you focus on your overall health.
Yeah, and I think men can rise to the occasion if there's some acknowledgement or if it's serious enough for them. For instance, I noticed that if you say to a man, you should get a colonoscopy, they're going to say, okay. But if their partner says, you need a colonoscopy, do it for me, then they'll do it. So they'll do it for love, but they won't do it for themselves. And so this is the kind of thing that's working. It's working. But I remember at a higher level of what Rob was saying, I spent my whole career in academics doing, genetics of infertility and epidemiologic studies and basic science stuff. And I realized at the end of the day, when I was a full professor, that the more I know about genetics, epigenetics, genomics, transcriptomics, metabolomics, and proteomics, the more I realized that diet and lifestyle matter the most for men's sexual health. The deeper I went, the more I realized it's basics. It's the basics.
I think, so for that piece, for the preprint that I wrote that featured Paul, I don't think I even realized the extent until I started to dig into it, that how, like one of the things that was really clear to me, and of course my analog is always women because I'm an OBGYN, but women have a cyclical monthly event that's tied to their health. And reproductive health for women is very tied to primary care and preventive care. And for men, like, it seemed like we didn't have a check engine light, but then I realized that sperm regenerates every 30 days, that actually, as Paul explained to me, motility is very sensitive to metabolic health and exposures. I ended up quoting somebody in this piece that said his sperm went from a graveyard to a rave, by like focusing on diet and nutrition. And it made me think, like, as a person who loves donuts, like, imagine, right? Like, that you could get your sperm to go from being a graveyard to a rave by like cutting back on processed carbs or something. These things that are really hard to do otherwise. And I was also thinking, like, for me to get healthy, my best biomarker in like the sort of incumbent system is cholesterol or my lipid profile. And like, it's just letters and numbers, and it takes 6 months to change. But if I could affect my sperm motility in like 30 to 60 days, and it's like dancing, I feel like that would be much more motivating, right? But it's not how we practice medicine today.
And I like the idea. You bring up a very important point with men that I've noticed, which is that they do respond to numbers and data. So if you tell them your blood pressure's off or your cholesterol's off, you can go after them, and they'll what do I do about it? They love numbers. If you just say, you should watch out for this, or, you have to give them a task.
Yeah.
And they do really well. So that's another little secret that might be different than women who may be more motivated. But, that cycle thing is a big deal. What men don't have a cycle, right? As a GUI gynecologist, I don't have a way to get.
Well, I'm looking for how we can do it earlier. Like, so every woman that is born when they go through puberty is seeing a doctor from that moment on. Can you see a future where there are the mavens for men that the country is supporting? And I do feel like the country and the world has gotten behind women and their health and having focus with somebody like you. And I'm here to advocate so that men can get an equal shot.
I think men certainly deserve it, so I hope so. I mean, I think, men have unique biological needs, but also I think there's an opportunity for us to think sociologically about how to affirm men in our health system. And I think even when I think about Maven Clinic, like, we are definitely attending to, unique biological needs of women and men both. But what gives us a lot of traction is the ways in which we affirm the context of women's lives in the care that we provide. And, I think it's very possible for someone to do the same from the male point of view.
We're going at a granular level about how men behave and how we can alter that. But I want to take it to a higher level, because you're consulting or work with the Office of Women's Health. The Office of Women's Health is a federal program. It's been available since 1991, so it's 30-something years old, 33 years old. And it has done amazing things for women's health. So it literally consolidated cancer care. It's made 80% of breast cancer curable. And it's an amazing feat because it consolidated all the nonprofits and gave them a house, a home. And maybe that's why these differences in men and women's health in America exist. But there's no Office of Men's Health. And it's not for a lack of trying. So I think in the 80s, a Texas senator, started, and I think 2 or 3 years ago, a Democratic senator from New Jersey or somewhere put another bill in the House for an Office of Men's Health. And I thought about it because I am a lobbyist for Men's Health Network in Washington, and they said, okay, it's coming up. And so the question is, we got to get active again. And it was sort of during COVID. It's a very partisan Congress right now. And, if someone wants something, someone doesn't. And it failed again. And I just don't understand what's going on with that. What is your perspective on this?
Yeah, I mean, so I just cycled off, but for their 3-year terms, and I think I had like a 1 year while I was waiting for my special government employee status. And it's kind of wild to join these NIH boards because you have to submit all your taxes, and it's like this rigorous vetting process. I served on the board through the pandemic, and it's, first of all, going to Bethesda on the NIH campus is really inspiring. Like, it makes me feel patriotic because you're like, we live in a country that has all of this for the sake of advancing and translating human knowledge to make people better, and it's like really like kind of awe-inspiring. And then you sort of get into it, and the NIH is organized by all of these branches, where is men's health housed? It's not that there isn't men's health, but it's really dispersed across, NCI, which does cancer, and the branch that does cardiovascular disease. And women's health had historically been the same way. There's NICHD, which is the National Institutes for Child Health and Development, which ironically, even though it's about children, is where women had been, and it's a small sliver. But the Office of Women's Health, of Research on Women's Health, where I was a part, their job was to coordinate across all the different branches and report it directly into the director of the NIH. And I think that's a construct that would be really productive for men's health. Absolutely. I don't know if we need a branch, but I do think that we would benefit from a coordinating office that looked across all these different areas of healthcare and said, what are the unique needs for men? What are the sex-based differences? What are the sort of gender-based ways of thinking about and providing care?
Absolutely. And, that is exactly the structure of the NIH is exactly the way men's health care is delivered, which is siloed care. You have an endocrinologist, you have a cardiac doctor, so if someone does your hormones, someone does your heart, someone does your internal medicine, and everyone's siloed and no one really owns men's health. And that's probably the significant difference, because you can imagine there's 40 grants for something to do with men, and some of them overlap, some of them could collaborate. And that's probably the magic sauce for why women's health is just on a different level.
I agree. I think even by its construction, our healthcare system has really evolved such that, if you break your finger, you go to a left pinky surgeon or something, and we really have broken the human body down into Atul Gawande actually has this great way of explaining it. He said the last century was the century of the cell, where we broke the human body down into its smaller and smaller component parts. And then this century, the big challenge is putting it all back together again, right? Mm-hmm. There's no integrator. And I think that certainly is a reason why I think men's health falls down sometimes. But yep. it also, I think, socially and politically advocating for men honestly feels harder. Mm-hmm. And that's why I started with empathy. You don't get that immediate sort of empathetic, yes, you have to explain yourself, and it's shocking to people that we live less long. I don't think many people know that.
I attended a White House dialogue during Obama's administration. It was talking about men's health, and it was around the time the Office of Men's Health was being considered again, and the Attorney General, you probably know the Attorney General, we started this conversation, and I was there representing, I guess maybe it was UCSF or something, but they had the YMCA there and several black caucuses and some sports teams and the Boy Scouts, and it's what can we do for men? What can we do for boys and men on this level? How do we reach them? And the first story that came out was Kevin Grimes, it was a mental health issue, and he jumped off the Golden Gate Bridge, and he survived. Mm. It's hard to know how many people have actually survived. I was at UCSF, and that was all kept very quiet because it becomes trendy, right? Yeah. And the story was that there were 3 miracles that happened to him. He hit the water, and he thinks the first miracle was a nurse was driving across the bridge, called the Coast Guard from her car, and saw it. The second was some seal or walrus, he thinks, pushed him to the surface as he broke his back. And the third was a neurosurgeon who I know at Marin General Hospital got the call and stuck around that night. Wow. So he was completely well, except he had some frozen ankles and a knee problem, and amazing. But the guy was we don't think about men like this. I mean, this is a huge issue. The other point was that what we came to a conclusion was it's really hard to reach men. And I stood up and I said, I can reach them because I have a follow-up proprietary program for following up on post-op patients where it's an algorithmic follow-up. It's a text or an email, and they check in every day with me after surgery. And I have a compliance rate of 95, 98% because I do it when they want, on their time, and it's not invasive. It's really convenient. We all concluded that the way to reach men is through their phones.
I think that we're on to something here, that we're going to reach men through their wives. So I just want to, because we're talking about family planning.
Or what if they don't have wives?
Well, then there's an issue, and your partners.
Well, the data is that a partnered male, not a married male, a partnered male lives as long as a woman in America.
Okay.
But an unpartnered one doesn't.
I mean, I think there's two things going on there. One is, I think that both of you pointed out that men tend to listen to their partners and do it for them, if not themselves, right? And I think certainly at Maven, like, we think about engaging men via their partners all the time. I also think that there's a lot of men out there who are just lonely and isolated, and I think that's sort of an independent thing that we have to also think about and run down if we're serious about, at a population level, improving men's health. There's the Surgeon General talks about this quite a bit, but there's an epidemic of loneliness out there, and it's not just among the elderly. I think when I think about who's most likely to be lonely, there's a lot of men, and I think part of the symptomatology underneath it is also how we're socialized. We're less likely to ask for help. Mm-hmm. In fact, I just saw a study last week that kind of blew my mind. So it was an operational engineering journal, I think. It wasn't in a medical journal.
I read those all the time, operation engineering journals.
So do I. No.
Is this a bedside reading for you, Neel?
Well, it was one of those internet rabbit holes, where you start off and you read the headline and then you're like, okay, let me go a little bit deeper into this. But basically, they had analyzed WebMD reporting, where people sort of report their drug-specific symptoms into WebMD. For women, there is signal, meaning it actually gives you some signal on side effect profiles. But for men, there is no signal because men tend not to report. They tend to just kind of suck it up. And if they do, they tend to be very vague. And I think that's just very, very interesting, right? Because the solution there is something way upstream about how men are socialized.
It's the check light you talked about. The check light is ignored.
Yeah, we don't have an obvious check engine, or we're not I think women actually are socialized to think about their check engine, right? Like if your periods are abnormal or wonky, you're attuned to it, and it's also normalized to talk about it with other women. Men don't talk about stuff, I don't think, at least.
No.
But to your point, they're super interested. So when I wrote this piece about sperm, I immediately, the next day, went to the gym and started talking about it. And now I bring it up at dinner conversations and everywhere. And when you're I think sperm's a better biomarker than cholesterol potentially, and people are like, what? And they're super interested. So
I think you're going to help us, Neel. I think you're going to help us.
Be the guy on the ground in the gym getting people to look at their sperm and not just their cholesterol.
No, but I love the fact that you're perseverating on what is the biomarker for men. Is it waist circumference? Is it testosterone? Is it semen analysis? Is it body mass index? There's got to be something simple. There's got to be a fifth vital sign.
Right, and so as an OBGYN, I've done, thousands of pap smears, and they're not perfect tests, right? I think this is the thing is we have all of these doctrinal ideas in epidemiology that are imperfect, but we forget. Pap smears are probably 40% sensitive, and they only improve their sensitivity when we do them serially for a woman in her 20s, every couple of years, right? But when I think about the sensitivity of a semen analysis for metabolic health, it's probably similarly sensitive. I have this sort of radical idea. I think the U.S. Preventive Task Force should take on screening semen analyses.
Because what we're talking about.
That's a great idea.
Yeah.
Right? It's the male pap smear, essentially, is what you guys are saying. I mean, I know it's not the same science, but to somebody like me, I understand that. If I was getting my male pap smear every 2 years when I turned 20, and I'm keeping it, there's a biomarker there somewhere that we could be.
I had somebody tell me that a semen analysis is cheap, easy, and pleasurable to collect.
Easier than a blood draw.
Easier than a pap smear.
Yeah, true.
Or a mammogram.
Don't require a doctor to be there.
Don't require a doctor. So I'm pretty bullish on the possibility of, when done thoughtfully. Paul, I know that you also taught me a lot about the complexity of QAing a semen analysis. They're not perfect, but none of these tests are. But if you do them serially and thoughtfully and with context, I think there's a lot of potential there.
Yeah, I think if a semen analysis changes with age, something's going on, just like if women's cycle. So the hospital Redefining in Copenhagen, I love the work they're doing. Uwe de Rappaport, they're working on trying to see if a semen analysis can detect cancer cells in the testis. So rare, it's a rare cell phenomenon. It's hard to find rare cells among common ones, just like trying to find fetal blood cells in a woman's blood. But the technology is moving very quickly. And if you can find in a semen analysis, if the testicle sheds cancer cells that ends up in the ejaculate, wow, you could screen for testis cancer. We're not even talking about health in general. We're talking about specific conditions that you could find.
Yeah, as an OB/GYN, I took care of a lot of people with ovarian cancer, which is a horrible, horrible disease. It's also nearly impossible to screen for. We've been looking for biomarkers for decades. Female gonads are internal, and typically we don't pick it up until it's fairly late stage, and it's a terrible disease. And when I think about the amount of R&D that's gone into trying to find a biomarker for ovarian cancer, when there effectively already is one, potentially for testicular cancer, you just have to get good at finding these abnormal cells. And again, to your point, if we can find free-floating fetal DNA in the maternal bloodstream, if we had the will, I think technologically we should be able to do it.
Absolutely. We need to throw money at it. And this is often Men's Health would say, hey, you're working on this, you're working on this. We should put a grant together, and centralize the money and focus it. That's what happened with Women's Health.
Tell me about at-home sperm analysis. So I know that that's something that is happening, and I know that I have heard from Paul that can't just be the only thing. But tell me about at-home semen analysis. It's at least a step that men can start taking.
So that technology for at-home collections of semen and even at-home assessments, you can collect it at home and get a readout at home, or you can collect it at home now and you can send it in and get a formal readout, laboratory readout. The technology's 30 years old. I've been involved in it since Fertility kit came out in the 80s and 90s, and I've always been a big fan of screening my whole career, and they've always failed.
How so? What does that mean?
Well, like the Fertel one got huge hits in the 90s and 2000s.
Oh, the companies failed.
They bombed. They were pretty popular in Europe, but there wasn't. I don't know why it failed.
Yeah,
it didn't do well until about 10 years ago, and I'm not sure what changed, but I'm very happy about it. Good. So something's better than nothing.
Yeah,
is my attitude. And so we're getting the screening. It's not perfect, but the at-home collection gives you a couple of pieces of information that can scare you to do something or not. And it's being used widely. It's private. It's men will do, and our partners will do it. So I'm fully a fan of it.
I would like it to evolve though, because one of the things I think about from my seat at Maven Clinic is there's a lot of things that are valuable to society that don't have a business model, unfortunately. And our healthcare system is such that, there's never a straight two-way transaction at scale. There's always some third party who's the payer or the purchaser, and they all have misaligned incentives. It's super complicated, right? And so direct-to-consumer things, they've taken off in a few spaces, including Men's Health, but first of all, they don't always make things better.
Right.
I don't necessarily think that taking, erectile dysfunction pills and turning them into a lifestyle medication was good for society. I think there's a lot of men, including men in their 20s, who think they have erectile dysfunction and their actual issue is alcoholism or something.
That's right.
Deeper.
You're going to miss the underlying problem, right?
I deeply worry about the Friday night ED pill as opposed to just like, let's step back and say, like, are you smoking? Because maybe there's like a red alarm bell going off, right? And maybe you have a cardiovascular condition.
That's right.
So, but that being said, what my dream is for at-home semen analysis is that we, to your point, Paul, I think men are very attuned to like data and are likely to be particularly attuned to data that connects to their virility, you know? And so like I envision somebody building like a 23andMe only with sperm. Like I think that could be super cool.
Let's do it.
Yeah, I agree with you. You have a very good point about a false sense of security. So if you get incomplete information, you might say, I'm fine, right? Or if your erection's fixed with a pill, when there's an underlying reason for it, you might say, I'm fine. I'm just going to continue to do this. But that's not preventative medicine. That's not great medicine because there could be something going on.
Yeah, and I think the thing that the male fertility industry can and should do is figure out the and then what. To your point, like once you get that test, you know, I don't want to trade on people's reproductive anxiety. I don't like that as a business model. Those business models do exist. But like people are interested and curious. So then what do you do with that curiosity to create an experience around it that ties to people's health and health goals, right? Like, and I think that that's possible because again, like it's related to toxic exposures and metabolic health. So by the way, and you've told me this before too, Paul, like you get most of what you need from a history and physical, right? So like if someone presents as somebody who could use help with their metabolic health or their toxic exposures, why not use a semen analysis as the sort of like tactical wedge to motivate them? And then why not socialize them around like the longitudinal possibilities of like, okay, it looks good now, but it could be like your check engine light. It's, you know, easy, relatively inexpensive, and pleasurable to collect. So let's just do it every year. You know, why not?
Yeah, and that's the good point. That's actually preventative medicine. You're saying you should be concerned about this and follow up. It's a preventative. It's the play we're trying to make. That's the play we're trying to make.
So what I'm hearing too, because I'm an entrepreneur and I'm thinking of business too.
I thought you were an everyman.
I am an everyman entrepreneur, but
and you make movies and you do a lot of other
That's
things.
right. There's a campaign here for the direct to consumer, the man that are out there that we're all kind of saying needs to happen. There's a bit of a PR campaign that's going to change this from guys like me, right? That's why we're here doing this. But if there's a buck to be made, then it'll be successful. It also leads me to any business now that is looking for funding is saying we do it with AI. And that transitions to your latest preprint that you focused on, the involvement of AI in fertility now, and especially in embryology. Mm-hmm. And so I'd love for you all to talk a little bit about how you see that side of fertility changing in the role of AI and technology going forward so that we can be better at it.
Yeah, I mean, I think like most people, I'm both excited and terrified of the role that AI is playing in society these days. And like most technologies, it can be used for good or for evil. But I think that one premise, just to throw out there, that I think is often, like AI is often framed as zero sum, right? It's like, and it's often positioned as a black box. So like, you know, AI is like some kind of magic wand that just does some stuff, and it can feel that way. And that AI is, the purpose of it is to replace humans. And I think embryology is a great example, or even andrology, right? Like the people who look at the sperm and judge it is a great use case for how thoughtful AI can, and really AI in the loop can accomplish what neither humans or AI can do alone, mm-hmm. right? If you put it together in the right ways. Like when I think about what are humans always going to be terrible at? Attention. We're not good at attention. So God forbid someone's looking at your sperm at 5 p.m. after a long day. I'd much rather have them look at it at 9 a.m., but I have no control over that. The computer doesn't care what time it is, right? And like, you know, in these sort of like boundary conditions, human judgment is usually better. Anyway, I think there's a lot of possibility. I think that there are many industries, embryology included, that are very artisanal today. And I see no pathway to democratizing access to these technologies without using more automation, which includes AI.
I think those are great points. Democratization is how you're going to expand this and scale it if it's such a boutique industry. and it needs to be available to more people at a cheaper cost. So even just making things cheaper. And I agree, I'm not worried about replacing humans, because it's interesting. I saw an interesting Japanese paper last week where they're using AI and the semen analysis and all the proteomics, genomics, and epigenomics, all this massive data to tell you based on your semen analysis, but not just on the numbers, on a deeper dive, whether you're going to be infertile or not. And it's not going to be perfect, but right now the semen analysis is a blunt instrument, right? It's terribly, if it's 0, you're going to have a problem. If it's anything else, you can't really say much, because it's always, it's a dance. So if you can go deeper on it, it's that's where it's going to be powerful, because it can assume data that you don't know how to analyze as a human.
So that's really exciting. Also, everybody, Paul has Japanese proteomics journals on his nightstand. But if you were to read them, what you'd see is exactly what he's saying, which is like the way that a semen analysis works today is a tired person looking through a microscope, and you're looking at the outside of the sperm rather than what's like inside it. And
the money's on the inside.
Yeah, but I mean, like, that's kind of wild, right? And imagine the possibilities once we have precision over what's happening on the inside of sperm. Imagine the possibilities when you can take human skin and turn it into sperm, which is very plausible in the near term.
Didn't you Didn't you have a grant? Yeah, I was to say he's turning
Cell arts. Yeah.
turning skin into sperm.
That's a tough one to raise money for. But in your article, you wrote, Leeuwenhoek in 1750 took a look at sperm, one of the first things, probably his own sperm, under the first microscope, and we're still doing that 300 years later, the same thing.
Oh, it's wild. So this person basically invents microscopy, and then one of the first things that they end up getting obsessed with is sperm, of course. So basically, like, as long as we've had microscopes and microscopy, like, we've been using it to look at sperm. And then, the initial take was that they were parasites, which is also very interesting.
Yeah.
But yeah, the way that we started to like classify sperm and think about sperm has not really evolved for centuries.
It's wild.
It is wild. And there's also lots of definitions of AI. So in your article, you mentioned robotics as an evolution of AI. And in embryology, the same thing. There is very delicate, you talk about your skill set in microsurgery. Mm-hmm. And then just for the guys that are out there, when we say we're fertilizing an egg with a male sperm and a female egg, there is a person that is injecting that in under a microscope. I've seen that a few times online. And I've joked that I almost got my vasectomy through my HMO. And when I got my checkup, the guy was looking at my stuff and his hand was shaking. And he was probably 3 months from retirement. And I'm literally like, I think I'd rather have Mr. Steady Hands over here than Mr. Shaky Hands. But I would say, in the scary or not scary, that when it comes to precision of putting that and doing it, the consistency, I actually would trust a robot to do that. There's some things that I want the robots to do, and there's things that I want for humans to do. And I think that you guys are at the forefront of how do we mix that? How do we use that?
Yeah, I think that's fascinating, right? Because, like, we've had the technology to have a plane fly from LA to New York by itself for like a half century, but literally nobody will get on that plane.
Yes.
And like, there are other cases where we seemingly have lots of trust in the AI, or have just like resigned to it or something. But I think that as these technologies get introduced, making them trustworthy is going to be really critical.
Right.
And part of getting there is going to be not conflating what we mean by AI. Like, to your point, like, there's different, for cars, there's actually formal levels of automation where, like, like cruise control is one and a self-driving car is another. And we often tend to talk about AI in healthcare as if it's all one thing, and it's not a monolith at all. But I think it's really interesting that you would trust a robot to do the micromanipulation. And there are people that are working on that I interviewed for that piece, and they're so bullish about this possibility that they're like, look, I mean, right now embryology is a black box. Like, you have your gametes collected and they go off somewhere, and you just hope it results in like a healthy embryo. But what we're going to do is, right in the waiting room, we're going to create a glass wall, and you're going to be able to look at the robot, and And they're going to see how it goes. They're opening their first clinics in the fall.
Like coffee in San Francisco in a glass box as a robot making your latte. But one thing I considered was a report. It was out of Oxford. It talked about AI has no moral or ethical structure. AI is iterative and based on data. It's basically giving you, if you're writing something, it's giving you what should come next based on a training set. So it's amoral.
Yeah.
And that's an interesting point. So so that's where it gets testy in humans. It's just going to do amoral thinking, right, for you.
Right. And well, here's the tie back. I don't know how your audience feels about talking about epistemology on a Saturday morning, but
tasty. Let's do it.
The thing that I'm most concerned about in reproductive health and in healthcare and in society writ large is that we're living in an era of massive misinformation and disinformation. And some of it's coming from inside the house of medicine, to be honest. Some of it is influenced by the political moment and all of that. Some of it, honestly, is our propensity to maybe overtrust technology, and that includes when it hallucinates and when it is optimizing a model but might not be doing the thing that's actually quote unquote right.
IVF is trending right now very much in this country. It is such a huge conversation, and it is one that both parties are agreeing on, that we should be pro-family creation in this country. So regardless of what side of the political fence you are, right now it seems to be that we want to support IVF in general. Okay, well that, and in the partners suggesting that you get yourself healthy for that, and this whole conversation, I'm saying that it has started and that it's guys like us that are going to push it forward. Neel, we thank you so much for being on the show today, and we're going to invite you back if you'll come back, because I really do think that we have a mission, at least, and I do, again, from the everyman. I am, and not just to start an awesome startup and we turn the 23andMe, which we're doing that. No, but I really do appreciate you coming on, and since you have been kind of pushing and pioneering and being the face and voice for women's health, it only benefits us to have you as a partner on the other side, and that we can continue to further this conversation so that it's a balanced one.
Well, I really deeply appreciate that. And, the passion and the commitment from your side is palpable, and it's inspiring. And there's something very ironic about being a man who had a career in women's health, but something about the fact that, I don't have the female experience has sort of driven this curiosity and maybe even empathy, right? I had no idea what women go through until I was in medical school, and I was like, oh my gosh, holy shit,
Mm-hmm.
And now I almost feel like I'm having this full circle moment where I'm contemporaneously living as a middle-aged man, re-engaging in my health and realizing that some of the very same opportunities that exist in women's health for decades, as we've been talking about, they also exist for men, and it's really, really important that we attend to them. So you guys are doing such important work, and hey, I'll come on anytime you want me to.
Oh my God. Neel, I think we're getting you on our side. We're getting you on the team. It's great. That mind, operational engineering mind.
Everybody that is listening, please, Neel, how can we follow things like Preprint, you on Instagram, or give us a couple of ways that our audience can follow you?
Yeah, so listen, I'm on all the platforms, Instagram, Twitter, but the one that I have come to enjoy the most, and the one that honestly gives me the most joy at work, is Substack. So in the day-to-day whack-a-mole of running a business, the one thing that I do every 2 weeks with a lot of regularity is write something thoughtful and nuanced about what I'm seeing from my seat at Maven Clinic, which is caring for 17 million people in 175 countries in all different walks of life. And it leads me to meet people like Paul and really dig in on what we can learn from sperm. It leads me to meet people who are building robots for embryology in Mexico City. It's really awesome. So the Preprint is a Substack that comes out every 2 weeks on Thursday mornings. And you can subscribe, and that's where to find me.
Wow. We highly encourage everybody listening and watching to do that, and join us on the next podcast. Absolutely. Neel, thank you so much. Really appreciate your time.
Thank you so much, Neel.
Thank you, guys.
Thanks for joining the Talk with Turek podcast. Today's show was executive produced by Rob Clyde and Jennifer Harris. DP engineered and edited by Drew Unser. Thanks to Avery Clyde, Shen Heckel, Max Flora, and Jonathan Raju. Talk with Turek is produced and recorded in Los Angeles, California, in association with Hey Babe Media. Subscribe to our show wherever you listen to podcasts and watch us on YouTube. For more information or to book an appointment, whether in person or virtual, visit Dr. Turek online at theturekclinic.com or call 1-888-TUREK-MD, T-U-R-E-K-M-D. Don't miss our next episode as we delve deeper into men's fertility and sexual health on Talk with Turek. And be sure to follow us on Instagram and Facebook at Talk with Turek for updates and more content.